We're very similar. We don't let our AI talk to the internet because there's a lot of nefarious things that can happen. So our AI, and so what we've done is we put our technician at your desk with your intake people. So they're integrated in and they help your people get the blood pressure, they help them get the weight, they help them get the height, and they're fully integrated there. And we use one technician per 1,000 patients, unique patients in your office. So if you have, if your practice is a small practice, one technician is fine. I've got practices with 3 to 5 technicians, and we put that technician in. That technician is allowed to do your vital signs. We actually do measure height. We don't accept the patient's statement of height. We find that the average discrepancy is 1.3 to 1.5 inches on height. And so we don't let them tell us what their height is. We actually measure it and we make them take off their shoes. We get an accurate height and weight so we can get an accurate BMI. Now, BMI is not the end-all be-all, but it is what Medicare requires us to report. So that technician is the one doing the engagement, and then they're getting the review of systems, which produces an index of suspicion, and then they're getting the information for what laboratory testing should be done. They will then, their next step is to advise the physician saying, hey, I got the information, the patient's significantly overweight, and based on review of systems, we believe that the patient should have this, and this laboratory test. Is that okay? If you agree and say, okay, yeah, that's fine, then they go ahead and draw it. Now, as in terms of the patient and the laboratory, we only use large labs. We don't use any regional small labs. We use large labs, and they're not allowed to balance bill the patient, and they're not allowed to bill out of network. So we don't allow the patient to get some gigantic bill that is inappropriate. The patient can only be billed in network, and there's no balance billing. So it de-risks that patient from that laboratory testing. When that lab testing comes back, it gets dumped into the AI, but we manually enter it. Now, we're also entering the demographics into your EHR. So when we're capturing the demographics for ourselves, we're entering the demographics into your EHR system. We don't let our system talk to yours because we don't want the AI to cause mischief for you. I've done a lot of work on AIs, and over time they degrade, and that's why we upgrade them every few months. And we use a fob lock to get into our AI so that it doesn't upgrade on the internet. We have to physically come to site, plug into the computer, and then upgrade the AI directly. So the information gets entered into your system, and 4 weeks later, we end up doing the Measura testing. Now, in that time period, we actually have a physician, we have 5 physicians, that will actually review the laboratory results, and they will personally review them as well as the AI. We want it to be reviewed by a human being. They're not billing for it, but they're reviewing the result, and they're making sure that the AI is not coming up with something stupid, because occasionally it will. I mean, these things can be a little randomized, and you have to be careful because they will hallucinate slightly. But we'll take that data, and once you get to the actual testing, it can't hallucinate because the testing is direct numbers. It can't hallucinate numbers. It takes the data and it puts it right into the report that we need. And it generates about a 30-page report with the exact recommendations for dietary and lifestyle intervention. And that is produced and given to the patient. And then the next step is, should you choose to have additional coaching, then you let us know, and